Hello, my name is Brian O'Donoghue, and I'm a psychiatrist with a service in Melbourne called Origin Youth Health, and it's a youth mental health service for young people aged 15 to 24. And I work within the early psychosis program and see young people with a first episode of psychosis. And I'm going to talk today about reducing involuntary admissions by identifying high-risk groups. So, to talk about involuntary admissions, unfortunately at times they can be necessary, but there's a number of negative aspects to it, including that they reduce and remove the autonomy for the individual. They can be traumatic, they can have a negative impact on the therapeutic relationship, and they can disrupt vocational goals as well. And this is some of the research that we did in Ireland, and I did it when I was doing my training with the St. John of God training program in psychiatry. This was done just over 10 years ago. And if we look at the number of involuntary admissions in Ireland over the last number of years, and this is from the annual reports from the Mental Health Commission, what we can see is that the number of involuntary admissions have been actually relatively stable, and on average is about 2,350 involuntary admissions per year. So so involuntary admissions affects a large number of people across Ireland. So then if we look at the most important question is, what can we do to actually reduce involuntary admissions? And a systematic review and meta-analysis has been done on this question. And the investigators found that there was 13 randomized controlled trials that included just under 3,000 patients. And what they found was that there was only one type of intervention that actually was successful in reducing involuntary admissions. And that was advanced statements. So that's when people set out in advance how they would like their treatment to be if they became unwell. And this showed a reduction of 23% in the proportion of people who had involuntary admissions. And they found that other things weren't effective in reducing involuntary admissions. And this included community treatment orders, which aren't in use in Ireland. We do have them here in Victoria. Other interventions they found to be not effective included compliance, enhancement, and also integrated treatments. That's sort of things like having crisis teams, etc. And if we look here, this is just a different way of showing the results. But there's a few things that are kind of striking from this. Firstly is that considering the severity and the importance of involuntary admissions, it really is, that does demonstrate that there's a huge lack of research in this area if only 13 trials have been done on it. But it's also very disappointing that interventions haven't been effective in reducing this practice except for advanced statements. So keeping this in mind that the majority of interventions to date haven't been effective, what I want to talk about today was kind of another approach at addressing this question of how we can reduce involuntary admissions. And I kind of just add a further challenge to this is that also involuntary admission rates vary from country to country. And this is most likely due to different legislations and practices in each country. So as I mentioned, a different approach could be if we identify clinical populations who are at higher risk of being involuntarily admitted. If we then understand why they have this increased risk and then develop interventions accordingly. So if we look at this from the other perspective about which patient groups are more likely to be involuntarily admitted, and this has been addressed in a meta-analysis done by this group here, and they found a number of factors that did increase people's risk for an involuntary admission, and they included males, being single and unemployed. But the two largest factors, and they had odd ratios of greater than 2, which means that they were twice as likely to be involuntarily admitted, included those people who had a psychotic disorder and also those who had a previous involuntary hospitalization. So I'm going to focus on the first one of these, which is people who have a psychotic disorder. And if we look and see about, well, what proportion of people who do have a psychotic disorder do have an involuntary admission, there's actually not a huge amount of research on this, but the research indicates that between about 50 and even up to 70% of people presenting with a first episode of psychosis can be involuntarily admitted. This particular study that was done in Canada found that the majority of people with first episode were admitted involuntarily. I think their figures were around 60%. So this is really huge. So this really indicates that the majority of people presenting with first episode can have an involuntary admission. This can obviously depend on the services in the particular area and how well developed the community services are. So to think about this again from a slightly different approach, one of the things that's been worked on within the service that I work in at Origin has been whether we can predict and identify the people who are at higher risk for developing a first episode of psychosis. And this has been termed the ultra high risk for psychosis, or the at-risk mental state. Really what it is that we can see that when people present with a first episode of psychosis, often if you ask them about the months before they present with the first episode, or even before developed, really what you usually hear is that for the majority of people, around 70%, that they had subthreshold symptoms or milder psychotic symptoms and also drop in functioning. So what they've done over the last number of decades is really try and actually kind of operationalize this criteria to see whether you could identify those people at higher risk for developing what we call transitioning to a first episode of psychosis. And this has been effective between about currently about 20% to about 35% of people will transition to who have been identified as ultra high risk for psychosis will go on to develop this first episode of psychosis. But this concept has received criticism more recently, and there's been lots of kind of perspective pieces about the concept of having at-risk mental state clinics. So the concept's been challenged. And the reason I bring this up is that what it actually led us to do was to look and see, to ask the question, what changes or effects do these clinics have that we mightn't have actually originally kind of anticipated? So we did a systematic review looking at the outcomes of those people who came through a at-risk mental state clinic, who went on to develop a first episode, comparing them to people who presented directly with the first episode of psychosis. So these groups of people both developed a psychotic disorder, but they had different pathways into care. So the first group through the at-risk mental state clinic, they were in the service when they developed the first episode, compared to people who just presented directly with the first episode. And what we found is that there were only 4 studies that we identified in our review, in our systematic review. And one of the studies found that those people who came through the at-risk mental state clinics were less likely to be admitted involuntarily within the first year. So this led us to look at this within our own service at Origin. And what we looked at data over the course of 5 years. And during this time, over 1,100 young people were presented with a first episode of psychosis. It's a very large service. It covers a very large catchment area. And of those people, 21% of people first attended either the at-risk mental state clinic or another one of our kind of specialist youth mental health clinics like Headspace, or we've got a specialist service for people with personality disorders. And what we actually found is that there was a big difference in the rate of admission to hospital, depending on whether you came in through the ARMS clinic or directly with a first episode. There was 17% of the people who came in through the ARMS clinic were admitted to hospital when they developed their psychotic disorder, compared to 55% of people who presented directly. And then if we look at those people who were admitted, what we found is that 71% of the people who came directly with their first episode of psychosis were involuntarily admitted, compared to 25% of people who came in via the ARMS clinic. So what we actually see is that there's a huge reduction in involuntary admissions for those people who develop a first episode and having first come through this at-risk mental state service. And the odds ratio was 0.11 or 0.11. But if you flip this around, what it actually equates to is that people who present directly with a first episode of psychosis and not through these ARMS clinics were 8 times more likely to be involuntarily admitted. And this is currently in press. We're in preparation at the moment. And actually it's a registrar who's currently working in Ireland, Tara Burke, who looked at this data and is submitting this work. And it's also good to know that these ARMS clinics are actually part of the National Clinical Programme for Early Intervention in Psychosis. So this is the proposal for the rollout of early intervention across Ireland. And it is stipulated in here that people should have an assessment and determined if they don't have a first episode, that they do have an assessment to see if they have the at-risk mental state. So potentially this is something that I do hope it's included in the model when it's rolled out, because it could actually lead to a reduction in involuntary admissions in this group. So then within this, I've identified obviously that the people with a first episode of psychosis have this higher rate of involuntary admission. But even within that group of people with a first episode of psychosis, there's a subgroup who have an even higher rate of involuntary admission. And that's people who are from an ethnic minority background, or who else are migrants as well. So what they did, again, this is done in a meta-analysis. A lot of work has been done in the UK, and found that people who had a psychotic disorder from Black Caribbean ethnic group were 2.5 times more likely to be involuntarily admitted. And similarly for migrants, they had a 50% increased risk of being involuntarily admitted. And we also looked at this in our own systematic review, looking at outcomes of migrants with a first episode of psychosis. What we actually found is that there was a higher rate of involuntary admission for those people who were first-generation migrants. And again, it's something we actually looked at within our own service, within the early psychosis program. And what we found is that migrants with a first episode of psychosis to Australia had a 50% increased risk for being involuntarily admitted. So similar to the systematic review, and the highest risk were for African migrants, who had twice the risk compared to young people who were born in Australia. And again, these findings are in press at the moment. We also looked at it in Ireland, looking at the DETECT data. And what we found there was that there was no difference in the admission rates for migrants compared to those people born in Ireland who had a first episode of psychosis. However, of the admissions for migrants were more likely to be involuntarily. So nearly half of the migrants were admitted involuntarily, compared to 37% of the people born in Ireland. So this leads to the next question: why are people from ethnic minorities or migrants more likely to be involuntarily admitted? And the answer is, at the moment, unfortunately, we don't know. Most of the studies in the systematic review offered no explanation for this kind of increase in risk for involuntary admissions for these groups, or they didn't offer any kind of data. They couldn't back up their hypothesis with data. Other studies have said, well, there's higher rates of psychosis in this group, but that actually doesn't explain it, because the comparison group is another group with psychosis. So that shouldn't have any effect on it. So the kind of other leading theories are that there's unfamiliarity with the healthcare system, in particular in migrants, which might lead to delays in accessing care, and therefore then leading to some more severe mental health difficulties at the time of presentation. Maybe due to the perceived risk of violence by the people making the assessment and determining the type of admission. And also, it has been shown that these groups are more likely to have police involved in their admissions as well. But we don't actually know, just to be clear, that these are actually theories, but we don't know why these particular groups have higher rates of involuntary admission. In terms of, and I think that's one of the first things we do need to do, but we are also, we are also trying to adapt our services. And just to give an example of potential solution, at Origin, we're establishing a hospital in the home service, which is acting as an alternative to inpatient hospital admissions for young people from the age of 12 to 25, where they get a high level of care from being seen twice a day. And in response to the data that we've recently seen with the higher rates of involuntary admissions in migrant groups, we're trying to tailor the service to meet the needs for this community. And it's a co-design project where we're going to involve young people affected by mental health disorders, and also their caregivers, in the design of the service. So therefore, in summary, if we, in terms of the first group, for those with the first steps of psychosis, so involuntary admissions could be reduced by identifying those people prior to the onset of the first steps of psychosis. So identifying people in the ultra high risk stage, or those with the at-risk mental state, and having them in the service, if they do transition, dramatically reduces down the rates of admission to hospital, and also involuntary admissions as well. But also, furthermore, if we understand why ethnic minorities and migrants are more likely to be involuntarily admitted, then we can develop interventions to reduce this practice. And if I just go back to the systematic review looking at predictors of involuntary admissions, the other one I focused on psychotic disorders, but also the other predictor was previous involuntary hospitalization. So again, I just raised this question that if we manage to prevent the first involuntary admission, will this help prevent subsequent involuntary admissions? And that's something that we can't assume to be the case, and again, should be explored in further research as well. And finally, if we just look at the original slide looking at the rates of involuntary admissions in Ireland, as I mentioned, that they've been very stable over the last number of years. And randomized controlled trials are really difficult in this area. But it means that if the rates have been stable over the last 4 years, that it means that we could look at pre and post changes if an intervention was introduced. And keeping in mind that even a small effect from an intervention, such as a 10% reduction, would mean a 10% reduction in voluntary admissions could mean that there was 240 less people being involuntarily admitted. So even a small change in this could have a very large impact for the people affected. So I'd like to thank you for having me, and I look forward to joining you all for discussion later. Thank you.